So, hello everybody, and thank you very much for joining us this afternoon. This it's going to be a very special session. We have the really who is who in endoscopic ear surgery joining us this afternoon, and Danielle Marchioni, who is the leader in this field, will be moderating the session. So I'm going to ask Danielle to take over. Danielle, can you hear me?
Yes, perfectly. Can you hear me?
Absolutely. Thank you, Danielle, for joining us. Of course, this feels like a family. We all know each other for so long, and happy to see you again. Since we don't meet physically anymore.
Yes, it's really a pleasure also for me, and to sharing this webinar for all these friends. And we hope that the next time we can see together, but in person, not on internet, of course. But anyway, I think that this is a great opportunity to sharing experience in endoscopic ear surgery, especially for board member and from the most expert in this field. And so thank you very much, Muad, for this opportunity to have this webinar in endoscopic ear surgery.
So who's going to start first, Danielle?
So can I share my monitor?
Absolutely. Please go ahead.
Okay. I'm not able to see Seiji in the list. Probably he had a problem. For the rest, all the participants are here. So I would like to share my monitor and start with 2 words regarding endoscopic ear surgery. And it's really important in my idea. It's to arrange this panel sorry, we know very well that now this trailer. We can start in this way. So the idea of this webinar is to try to have to understand better the situation of endoscopic ear surgery in 2020 after more than 10 years of experience with the endoscope, and especially it's really important to have some answer from some question regarding endoscopic ear surgery. So my idea is to start in this way. We have a large faculty and with the really important name of endoscopic ear surgery. Everybody are friends, but also big names of endoscopic ear surgery. And I would like to set the webinar in 2 parts. The first part just for some simple question and discussion. And the second part just to show clinical cases when the endoscopic ear surgery was, of course, useful or was unuseful. I heard some noise anyway. So we can start with the first part, and if it would be possible to see the list of all the name, but we can start just to present our panelist, of course, Muad Tarabici, that we know very well, and is a father of the endoscopic surgery, and also the pioneer in this technique, Daniel Lee, that is a pioneer from Harvard.
It's coming from your computer. Okay, one second.
Yeah.
All right.
Okay. And Daniel Lee, that is a pioneer of endoscopic ear surgery in the US and working in Harvard University, and everybody know him. And also, of course, Livio Presutti is working in Italy, one of the pioneers of endoscopic ear surgery, the past president of International Working Group and the chairman in the Modena University, Italy. And Stefana Yash was the idea originally of the international working group was from Stefan, and I remember very well the meeting that we did in Turkey, and he is a founder of the international working group and is working now in the University Center in Cannes, in France. And of course, Mohamed Bradleddin, also now he is the president of International Working Group, as a professor in the Alexandria University, and also president of Skull-Based Society, Egyptian Society. And Nirmal Patel, one of the pioneers in Australia, so is also a secretary of International Working Group, is working in the University of Sydney. And Seiji, that I don't know honestly if today he's able to stay with us, and but anyway, he was a pioneer in Japan, and now is the chairman in Yamagata University, and of course is one of the founder of the International Working Group. And João Flávio Nogueira also is assistant professor and pioneer in Brazil of endoscopic ear surgery, is a director of a Sinus Otto Centro in Fortaleza, Brazil. And Mohan Reddy was a pioneer of endoscopic ear surgery in India, is a founder and director of a chief consultant of Nova ENT Hospital, and president, of course, EVA in Hyderabad, and one of the board member of International Working Group. Alejandro Rivers, and was a pioneer in the US, and now, just now, is moving from the university from Nashville to Cleveland, and now he's the chief of otology and neurotology in the Cleveland University Hospital. And George Wanna, another pioneer from US, and now is a professor of otolaryngology and chairman in, of course, New York, Heisen here Infirmary, Mount Sinai, and the chief of division of otology and neurotology and director of audiology, Herring Byland Center, and also Daniela Carvalho, that is a professor of otolaryngology at the neck surgery, pediatric otolaryngology in the University of Rai Children's Hospital, San Diego. So I think that is really important faculty, and so we need to start now, because just a simple question, probably we have to spend a lot of time in order to answer the question, because we are a lot of panelists. The first question, my idea is to understand from you, now 2020, after 10 years of experience of endoscopic ear surgery, what about the indication of endoscopic ear surgery today? Do you have some idea regarding the indication of the total transcanal endoscopic approach? And I would like to know your feedback. And so before, of course, Muad can answer to this question. Please, Muad.
Well, basically, you know, the most impact that I see in terms of day-to-day practice is the fact that we're doing less and less mastoid procedures. You know, a lot of times, you know, after I start in like my endoscopic case, and after like going through it, I ask myself, like, what would a mastoid have done for me in this situation? And I would say in about 50% of the cases, really the mastoid is at least the mastoid is not involved, doesn't need to be addressed. And I find that the major impact that I see in my day-to-day practice is a significant drop in mastoid operations and more access into the tympanic cavity and the retrotympanum and the protympanum, basically to remove disease and as well as to visualize pathology and understand what's going on.
Okay, so the idea in your mind is just for cholesteatoma, or do you think that, or chronic ear disease? And I would like to know the feedback of Daniel Lee.
Do you want me to open up the microphone for Dan Lee? Because
Okay, yes, please.
let me do that for you.
Okay.
I opened up the microphone for Dan. 1 second.
Thank you very much, because, okay.
I'm trying to open up the microphone for Dan. No, it's not opening. Unmute, and I'm pushing very hard.
Okay, I can try for you if you
Oh,
want.
here we go. Here we go. He opened the microphone. Okay.
Hi, Daniel.
Good morning from Cape Cod, Massachusetts. Daniela, thank you for including me, and Dr. Terabisci, thank you for helping organize this fantastic Zoom event. I'm thrilled to be here. So, indications. It is surprising even to myself that in my practice, virtually 100% of my middle ear dissections for any indication are now being done endoscopically. And so, and I don't think that there's ever a reason to necessarily go back to the microscope. I think the one exception would be those large, bulky, bloody paraganglioma glomus tumor cases where one truly needs a second hand for suctioning to keep up with the bleeding during tumor removal would be the one indication that I really haven't pushed the envelope with. For small glomus tumors, pretty straightforward, but for anything larger or with more bulky disease, I feel much more comfortable going back to the microscope. So indications, really for me, it's any case that requires middle ear dissection. I now use the endoscope exclusively, transcanal. And I think an area that isn't always talked about that I like to emphasize in my presentations is the transmastoid endoscopic dissection of chronic ear disease. And so much like points that Dr. Terabisci just indicated, I too have not done as many mastodectomies for chronic ear disease, and the number of primary canal wall downs that I perform for extensive cholesteatomas is extremely small numbers these days, which has influenced the kinds of cases exposed that the trainees are exposed to. And so in our practice now, the mastoid obliteration is the most common indication for canal wall down to address CSF leaks, not cholesteatoma, which was a real flip in our practice. So I'd say broadening indications is increasing use of the endoscope for transmastoid dissection to preserve the canal wall. I think that's an indication that I think a lot of our colleagues who are just learning endoscopic techniques would be in favor of as they begin their forays in endoscopic techniques. So thank you for having me, Daniela. Nice to see you.
Nice to see you, Daniel. And Livio, where is Livio? We have to unmute Livio.
Yeah, I just did.
Okay.
Hi, can you hear me?
Yes, yes.
Hi. Good afternoon, good morning. It's very nice to see you all, dear friends. Very nice. So about the indication, I think today we have a lot of indication of exclusive endoscopic approach. In my opinion, all disease involving tympanic cavity and aortic can be treated by exclusive endoscopic approach. For example, meningotomy with insertion of tube, meringoplasty or sacroplasty, aortic cholesteatoma, retrotympanic cholesteatoma, or also stapes surgery, primary stapes surgery or revision stapes surgery. In my opinion, also small tumors of tympanic cavity like glomus tumor type A or small acoustic neuroma. All this disease can be treated by exclusive endoscopic approach. In addition, we can use endoscope in combined approach like extensive cholesteatoma involving mastoid cavity. In this case, I usually do first step endoscopically for tympanic cavity and aortic area, and then I take microscope and I use microscope for posterior area. So Today, I use, of course, both. We will speak later about contraindication or when the microscopic is the only indication for ear disease, but I use more and more endoscope today.
Okay. And Stefan, do you have some other kind of indication, or you agree with Livio?
Yeah, hello everybody. I'm very happy to see you all. I hope that we will have the opportunity to see physically in the future. Yeah, my opinion is the same than Livio. I think that today, for me, concerning the endoscopy, this technique is the main approach for all ear surgery, with the limit, of course, of extension of cholesteatoma in mainly in the mastoid. Maybe we can push indications until the antrum, but not in the mastoid. So the main limit for me is the extension in mastoid cavity for cholesteatoma, and also the anatomy of the ear canal could be a limit. I say could be because we can, of course, perform canaloplasty with an endoscopic approach. So concerning tympanic membrane perforation, ossiculoplasty, stapes surgery, cholesteatoma, even when we know at the beginning that the cholesteatoma involves the mastoid, we can of course begin with the endoscopy, and like Livio, the microscope is then a complementary device to the endoscope. So the surgery is performed with the endoscope, and then we can use the microscope when we cannot use anymore the endoscopy. So for the mastoid. Thank you.
And Mohamed, do you want to add something?
Well, first, thank you very much for this perfect webinar, interesting webinar. And again, I'm also very happy to meet you all. And, you know, what was said about the question, I think we may need to go for new questions, because everything more or less was said. And I will just follow exactly what Livio was just saying and what Moaz said, what Stefan said. So I just don't want to repeat it, but in a nutshell, I will say now that in every indication, otological indication, I will start using the endoscope and get the microscope to help me if I need more extension of the surgery. But endoscope for me will be always the start of the surgery, and then get, if I need to extend my surgery, if I need to, or I need a second, not really second hand, because I can use the assistant second hand, but an extension to do the surgery, I will use a microscope. So it's an endoscope microscope that will go in all fields of otology. This is my indications.
Okay. And Nirmal, I would like to know the opinion of Nirmal. The question is because at the beginning, now we are in 2020. So we spend a lot of years performing these approaches. And before there was a big resistance from otology community. And so my idea is to understand now, after 10 years, if you are changing your idea regarding the indication of endoscopic ear surgery, or the indication are the same at the beginning. So please, Nirmal, can you answer the question?
Thank you, Daniele, and thank you, Moaz, for the organizing. Welcome, everyone, and hello from Sydney. The difficulty for us now is that our residents think that everything is an indication for endoscopic ear surgery. And I think one of the challenges we have, just to add to what everyone said, is that the registrars and our residents are very enthusiastic about the endoscope for anything in the middle ear. And sometimes we have to actually remind them that there is the microscope, particularly like Daniel said, where he mentioned where there's excessive bleeding or disease around the stapes, where there's excessive granulation, where we need two hands. Sometimes we have to pull our residents back and say, yes, bring the microscope in sometimes when you need to cut flaps or dissect tissue two-handed, or you need to control bleeding. So in general, I don't have much to add. We teach our residents that the middle ear is really the domain of the endoscope, but we still need the microscope. And then when the disease extends past the posterior end of the lateral semicircular canal or into a deep sinus tympani type C, then we do need to perform a mastoidectomy to reach disease in these regions. But I think one of the challenges for us is to maintain the skills of the microscope as well as we're teaching our residents the endoscope. So for us, indications really across Australia, I think now most people would agree that it's probably the middle ear for the endoscope, and the mastoid is the domain of the microscope.
Okay, and I don't know if Seiji is with us. Probably is not able, and so the question now is from is for Joao. Please, Joao. And do you want to add something? Hello, how are you?
Yes, it's nice to see you all, and it's good to see that every one of us it's overcoming this pandemic situation, which was so bad here in Brazil and also in other countries. But just to add, the compliment is nowadays for me, any ear surgery can be indication of the use of endoscope, and also for the residents and for everyone that comes here to see the service, we show the use of endoscope also in office, because I think it's important in order to get the eye-hand coordination for the persons, for the doctors who want to use endoscopic in-ear surgery. It's good to start also in the office, cleaning the ear canal, showing for the patient the perforation or the cholesteatoma that the patient has. So I think one other indication of the many indications that were said today is the use of endoscope in office to clean and to inspect the ear canal in the office.
Okay. Mohan Reddy from India.
Yeah.
Where are you, Mohan?
Yeah, I'm here. Can you hear me? Can you see me?
Hi, how are
Yeah.
you?
Thank you so much, Daniele and Maz, for arranging this meeting. I feel like, meeting you all as family again, I say. And coming to the indications, Daniele, everything is told already. I will tell my experience when I started in long back in 90s. My indication, I started surprisingly for a cholesteatoma to begin with, and I was doing a modified combined approach tympanoplasty with a microscope by that time. I was using microscope for cholesteatoma, and I just thought of using endoscope for improvising the combined approach tympanoplasty at that time. My first case was that combined approach tympanoplasty using endoscope to minimal episiotomy, transcanal, and then going back to the transaditus tympanomastoidectomy. That's what I presented at that time, no cavity mastoidectomy. So my view now is we can classify the indications like this. As Mohammed told and Joe, all ear cases, we have to have endoscope with us along with the microscope. Or rather, 80% of our otology work we can do now with the endoscope, and we reserve the microscope for the bone work and the deep dissection wherever we need to use two hands, certain areas like that. And our indications mainly fall into three categories. One is to minimize the wide access techniques where the access is a problem earlier. With the microscope. Now we are able to do all the middle ear surgeries using endoscope, transcanal, complete total endoscope. Other thing is to improvise our techniques, like improvising the results of combined approach to how I started. So now we are able to do with a good results, and canal down techniques are minimized now. So that combined approach tympanoplasty, we are using endoscope as an innovative tool. So we can call it as an ECAT, endoscopic combined approach tympanoplasty, which I presented in our national conference in that term. Probably we can use that ECAT. So we can divide these indications like this, all in the ear cases. Both the tools should be used. There is no exclusion of one against the other. We have to use, these are tools. So both, and we have added another tool now. So all ear cases, and we can divide the endoscope for 80% of the otology work, because mainly our otology work is a middle ear. That's how I can put it.
Thank you, Mon. And another opinion from Alejandro. And my question is also this: in US, for example, do you have some resistance for some indication? For example, tympanoplastic type 1. And now it's natural to perform it through the endoscope, or there are some resistance again now?
No, I don't think that I don't feel that there's resistance necessarily. I think that there's people decide what they like to do. There are surgeons that like to use the microscope, and they use the microscope, and other surgeons like to use the endoscope. They use the endoscope. It is funny. I do agree with the fact that the expectations have changed over time. Now that I'm in a new institution, I'm setting up my OR, and as I'm setting up my OR, they expect me to do everything with an endoscope. And so if I have they thought almost if I have a acoustic neuroma, they're asking me, okay, you're gonna start with the endoscope, a big 3 centimeter acoustic neuroma, you're gonna start with the endoscope. And I said, no, I'm a neurosurgeon. I still do mastoidectomies. I still do use the microscope. So those are things that the expectation has changed. Yeah, now at university hospitals, an endoscopic guy is coming. That's my new title there. And so it's a matter of expectations and what the right indications for the endoscope. And I agree with everybody. The endoscope is for the middle ear. There's instances where you can use it in the mystoid or in the skull base. But when I'm drilling, I still prefer to drill with a microscope as a matter of efficiency, primarily.
Thank you, Alejo. And now, George, where is George? I'm not able to see him. Where is George?
I'm here.
Oh, hi, George. No, okay.
Good to see everybody.
Hi, George. Please, your feedback about the indication.
Thanks for having me, you and Muaz. And it's good to see everybody healthy. And I'm glad that at least we can connect in some way and form over the internet. I don't think there's much to add except a couple of things, at least the way I think about it. If you want to do exclusive endoscope, I think the middle ear is the only way to be claiming that. And depending how comfortable you are as a surgeon, you can push the envelope to do more than that. But I think the most important thing of that is the outcome of the patient. So we have to keep in mind whether you decided endoscopically to train residents or microscopically, as long as the outcome are similar, that's okay. If you have one in your hand worse than the other, then you have always to put the patient as first. So in the US and in New York, it's very important to be comfortable in both for 2 reasons. One, because you're gonna need both at sometimes in the same time. Number 2, when you go out and you're gonna be practicing in different areas, then you might not have access to everything you want. So you're gonna need to get training in both. That's why we diversify. Even on T-Plasty, I will let residents alternate endoscope and microscope so they can be comfortable. And we do have the exoscope now. It's another tool. So where this will stop. So I don't want to take a lot of time. I think the middle ear is a way to start to train people and let them grow into it, as long as their outcome down the road will be equal to if they are doing other, which mean microscope. And then if you are comfortable endoscopic ear surgeon, you can push the envelope as far as you want, as long as the outcome of the patient is good. And that's what I have to add on that. And thank you.
Thank you, George. And Daniela, I know that you are working in a children's hospital. So what about your opinion in indication endoscopic ear surgery, especially in children?
Absolutely. Well, first of all, thank you so much, Daniele, for the invitation. This is wonderful. I've been part of the international working group for 10 years. I know several of you. I've been doing this for 15 years. So In kids, this has been a huge game changer, as it has been in adults for sure. But when it started 15 years ago, we only had large endoscopes. And I can tell you that now we can actually really push the envelope, as George was mentioning, and do kids that are syndromic, very small ear canals. And literally the sky is the limit. Again, when you're talking about middle ear disease, and if you're talking about epitympanum, and we can avoid retroauricular incisions and avoid mastoidectomies. The parents are thrilled about it. And I do believe the endoscope is a great spy. You can look and, with the assessment with the endoscope, you can clean that middle ear and the epitympanum and up to the antrum sometimes, very, very well, much better than with what you could do with the microscopes. I do believe that the results are better too. So after everybody, I agree with all of you, and it's absolutely wonderful to be here.
Thank you very much. And now we can pass to the other question that is really, really close to the indication. I would like to know the limits of the transcanal endoscopic ear surgery. And at the beginning, we decided that the limit is the antrum, and behind the lateral semicircular canal, of course, is territory for microscope. I would like to know from you if also now this is the limit of a transcanal endoscopic approach. So Muaz, if you want to say something, but just yes or no, or some comment about this.
Well, this is really the biggest lesson that I've learned throughout these 24 years, is that I really now try not to pursue disease posteriorly in the attic. I think, again, there's a real value to preserving the scrotum, and I'm a lot more inclined towards going back and doing a post-auricular incision to basically attack mastoid disease. Anteriorly in the attic, I have no problem really taking down whatever to reach. I think anterior attic is also the area for the endoscope, but posterior attic, I'm very, very conservative nowadays. And this is one of the biggest changes that has happened in my practice of endoscopic ear surgery.
Sure, the answer is yes. Daniel Lee, please. Daniel, where are you? Okay, now we can hear you.
I would agree with all of the points raised by Dr. Terabishi. I don't think the limits have changed too much. Once you get past the dome of the horizontal canal, it's just very challenging with existing technology to be able to address that disease and to actually remove it. And I would also echo the comments of Dr. Terabishi about, the more bone you remove from the scutum, I think it's more difficult to reconstruct, and I think that could have some impact on some of the hearing outcomes as well. So I think the equipment hasn't really changed significantly over the past 1 or 2 decades with regards to endoscopic techniques. And so I look to the next decade as an opportunity to challenge our industry partners to push the envelope and bring us some tools that can better make the turn around the corner to allow us to address more deeply embedded disease without having to remove additional bone from the scutum. So.
Okay, so also for you, the limits is the entry. Okay, and Livio.
Yes, I agree. Limits can be still the lateral canal, but I agree with Muaz. I mean, when you do the most important work on tympanic cavity and attic, and if you have a small remnant of disease in the posterior aspect, in the mastoid, you don't need a lot of work. You just need a small incision and a limited mastoidectomy, because this is a new. We understood that the mucosa of the mastoid cavity is really important for physiology of the middle ear. So we have to avoid a large mastoidectomy. We just need to see the posterior limit of disease with a small mastoidectomy. So this is another thing. It's not really classical closed technique. It's another thing. We do the most important work on middle ear endoscopically, and then if we need, we can take microscope and we do just a small, a limited portion of our procedure by microscopic approach. So it's really important to say about this. It's another thing. When we use endoscope, we change our mind, and we have in mind another physiology, another final result of our surgery. This is the real point. It's not a classical limit endoscopically till lateral canal, then microscopic to a large mastoidectomy. No, it's totally different, our approach. I mean, my mind, I changed my mind about, for example, cholesteatoma.
So also for you, the limit is the antrum, anyways. And Stefan.
Mastoid, maybe the antrum, we will in the future push the indication with some technique of obliteration, but we can discuss with that later. But the main limit today is the mastoid, and in fact, we have to remember that we are the surgeon of the ear. So if we need a microscope, we use the microscope to do a small mastoidectomy just to get access to the cholesteatoma to remove it, and then to go on with the endoscope from the posterior epitympanum to the anterior epitympanum with the posterior approach. So yes, today for me, the main limit to use the microscope, the main limit of the endoscope to go to the microscope is the mastoid.
Okay, and Mohamed. Please, Mohamed. Oh, sorry.
Okay. I agree exactly with what we said. I'm just highlighting one point that you have your endoscope again, and you can use the endoscope transcanal or transmastoid. So even when you do a small incision, or if you do a small like antrotomy, you still can use the endoscope as a transmastoid, and you can remove if you want, or if you want to check or something. So endoscope can go both ways, transcanal or transmastoid, and this will help you getting both in the same time. So the same limits, but get the endoscope again through the transcanal, through the transmastoid approach, and it will help you. It will make your incision and your surgery, the post-auricular incision, less extensive.
Anyway, the limit is transcanal.
It's the same.
The same. And please, Nirmal. Nirmal.
Thank you, Daniela. Yes, I don't have a lot to add to what we've already discussed, except for just to include type C sinus tympani disease that can extend fairly deeply past the posterior aspect of the facial nerve, and that often needs to be addressed with the microscope. And the other thing that's changed in my practice is that when we used to teach the limits of endoscopic ear surgery, we used to speak about the posterior end of the lateral semicircular canal, the sinus tympani, but also complications. We used to say that whenever there was something like, for example, a tegmen dehiscence that may need repairing, or a lateral semicircular canal fistula, that would be the domain of the microscope. And more, sometimes if we're able to, we can sometimes do these cases endoscopically as well. So that's the only slight change in my practice over the last 8 years or so.
Thank you.
But yes, the antrum.
And this the question the same of Joao, but for example, and when you have a contract mastoid, and do you perform retrograde mastoidectomy with the endoscope, or the limit is only the lateral semicircular canal?
Yes, this is a great question, Daniele. I would say it's a matter of efficiency of the surgeon and the patient when we talk about OR time and when we talk about the use of the instruments. I like to say that for me now, the limit, especially in cholesteatoma, it will depend on the matrix of the cholesteatoma. Because if you want, you can go and chase the cholesteatoma all the way inside out from the middle ear all the way to the mastoid tip. But this is not efficient, because you will lose a lot of time just to do the bone work, the inside out mastoidectomy, and then at the end, you will need to reconstruct. So if you have a non-infiltrative matrix cholesteatoma, even if the cholesteatoma is big and overpasses the limit of the posterior semicircular canal inside the antrum, you can remove the cholesteatoma, just like washing the cholesteatoma, it will pop out in the middle ear. But on the other hand, if the cholesteatoma is small, but it's infiltrative, you will not be able to see, especially if you don't do a big athecotomy, the medial part of the scutum. So you will leave cholesteatoma over there because the cholesteatoma infiltrates the mucosa and the bone. And this is not going to be good. So for me now, it's not a matter of the limit of the anatomical limit, but rather a limit of the matrix. So if I have a small infiltrative matrix cholesteatoma, most of the times I do a combined approach with a small mastoidectomy, as Professor Prezzuti said, just in order to check the medial part of the scutum, the median wall of the scutum, because with the endoscope in a transcanal way, you cannot check at this point. But on the other hand, if you have a big cholesteatoma that overpasses the limit of the posterior semicircular canal, the lateral semicircular canal, but the cholesteatoma is a non-infiltrative matrix, you don't even need to do an athecotomy. You can remove it totally transcanal. So it's a variable limit, I would say like this.
Okay, so for Brazil is a variable limit. And now, Mohan, what about the situation in India? The limit is the lateral semicircular canal, or you are performing also retrograde mastoidectomy more and more? And do you have an anatomical way of thinking? For example, if you have a really pneumatized mastoid, you can do combined, or if you are sclerotic mastoid, you can do transcanal retrograde. This is just my question, because I know that in India, somebody they are performing retrograde mastoidectomy, and so the limit is not the lateral semicircular canal. But I would like to know your opinion.
Yeah, as I told, I started the combined approach with the endoscope trans-Adytus approach for ethic exploration. So my transcanal limit for endoscope is, as I classified for a cholesteatoma, is a horizontal facial canal. If the cholesteatoma goes beyond the horizontal canal, probably in certain cases, I may be able to remove with the endoscope with a little outer attic wall removing. But sometimes I may have to. I classify it as type 3. And then if it reaches the Adytus, then definitely I use a combined approach. That is a type 3 some cases, and type 4 when it reaches the Adytus and antrum. So there I use both of post retrograde mastoid and all. In a contracted mastoid, as you told Daniel, is a very, very important in these cases. Sometimes it will be so sclerotic. If you do a limited mastoid also, we will be entering only just the antrum. We'll be seeing only antrum. Everything else will be sclerosed. And sometimes the canal will be narrow in such cases. And the ear canal also be narrow. They require kind of a canalplasty. So such cases, probably the endoral transcanal, endoral approach inside out microscopic technique may be the best choice. Such cases.
Alejandro. Alejo.
Yes, I'm here. So no, I don't have much to add. I think that limits in atresia surgery, I think that's a limit. If you have a complete atresia, I would say that I use the microscope to create a canal in those patients that I offer that option. If now at the same time, I can say that I have wide and ear canals with an endoscope and with a drill. But I gotta say that is not the most efficient way to do it. And so again, I think that when I'm in terms of efficiency, drilling allows me to move a little bit faster with a microscope than an endoscope. So anytime if I'm gonna do a very wide canaloplasty in particularly in atresia kids, I'll use the microscope, and I think that that's a limitation as it stands right now. Now, if we were to talk about exoscopes, I think that is a new technology that is available, that you can drill efficiently with an exoscope. But and I think that we will get there at some point with exoscopes to drill with them and to hands. it's very doable. I think it's a matter of cost. We've always talked about endoscope as being a very economic option for middle ear disease and to remove disease. I think that when we start talking at the range of good level exoscopes, that cost for instruments rises. And so the advantage kind of starts to disappear a little bit in terms of costs when we compare the use of the endoscope and the use of the exoscope and the microscope. But at the same time, the ergonomics, and Dan Lee can talk a lot more about that. The ergonomics on an exoscope potentially would be beneficial.
Okay. Yes. George.
I don't think I'm going to add anything, Daniel. It's just straightforward question. So it's no, I think the limit is still the same for me. Behind the posterior, the lateral semicircular canal posterior, I will stop.
Okay. Also for Daniela.
Yeah, so I'll tell you, it's fun to be last because everybody said everything. But I would also add, the limitation is also the comfort zone. I mean, you have people that are just starting and are not going to feel comfortable doing certain things, and you're going to have very experienced surgeons that can do a lot more, going beyond, for example, the lateral semicircular canal. Another area, for example, that we do a fair amount of very extensive cholesteatomas is the supratubal cells or recess. So a lot of times, it's easier if you go do a small enterotomy to actually deal with that area with straight instruments instead of having to use curved instruments and go beyond the malleus and so forth, if you want to keep it intact.
Okay, and just in a really fast way, and somebody of you can give me some contraindication of endoscopic ear surgery. Do you think that there are some contraindication, or at present no contraindication for transcanal endoscopic approach? For example, if you receive a patient and you can see and you can check the CT scan, and you are thinking in your mind, no, this is not good for endoscopic, and I want to perform just with the microscope. Somebody of you can give me some feedback about the contraindication? This is free. It's a question free. So please. So we can start with Daniela, and so we can go in this way because of
ladies first, right? So
yeah.
So no, I agree with Dan. When Dan mentioned about large glomus tumors, for sure, that's anything that's too bloody and it's going to require you to be suctioning, a second hand. You're definitely I think that is a contraindication. It makes it very difficult. And again, you have to think about efficiency and most of all, any possible complications for the patient. So I think in that case, it's definitely a contraindication for endoscopic sinus.
George, for you, there are some contraindication. Are there some contraindication? Where is George?
I don't know where is George. He disappeared.
Oh, disappeared. Oh, so we can. Alejandro, where is Alejandro? Yes.
I'm here.
Oh, okay.
I'm just adding more coffee because I drink a lot of coffee, as everybody knows.
You need. So, George, regarding the contraindication, in your opinion, are there some contraindication for endoscopic ear surgery?
I think the contraindication can be relative and the absolute one. The absolute one are tumors that extending beyond the limit of the middle ear and the mastoid, or some extensive into the neck from the ear or anteriorly. The relative, honestly, it depends on how comfortable you are. It really is. I mean, if you see Livio doing a stapes on a case was aborted by a famous surgeon in Italy because of the facial nerve was completely covering the foot plate. That's a contraindication for 99.99% of the people who do endoscope, but it was not for Livio. I think a big part of that is the experience of the surgeon and how comfortable they are, and that should be the relative part of the contraindication. There is the disease, which is the extensive one, the vascular one, the tumor one that extending beyond the limit of the middle ear, an area where you need two hands. And there is also the expertise of the surgeon that sometimes you need to not to do the endoscope, and that's both are valuable point, I think.
Leo, in your opinion?
All right, there. I don't have much to ask. I agree with George that those are the contraindications.
For example, if you have a patient with a problem with the blood exam because you are expecting the bleeding a lot, or you have a really narrow canal, no contraindication.
No, as I said before, I think that in very narrow canals, I personally I've done it both ways, and I think that that is a relative contraindication. If you have no canal, that's an absolute contraindication, because you have to create it. You need the microscope. You need to drill. If you have a stenotic canal, I think that you can use the endoscope, but it will take you more time. Okay. And you have to be prepared for that. I've done it both ways, and when I started, I tried to do everything endoscopic because I wanted to get very good at it. And as I did more and more and more, I realized that maybe even when I was when I thought that I was being efficient with the endoscope, I could have been more efficient with a microscope. In a sense that drilling a canal and widening a canal in a very stenotic, in a congenital stenotic children, for example, that made a lot more sense. And so that is relative. Depends where do you want to spend your time and how do you want to spend it. And I think that you can do it both ways, but certainly one is more efficient than the other.
Okay, and for Mohan, some contraindication?
Yeah, I think this is a tool, I think, as we discussed, both the tools we use, how much time with what we do in a particular given case depends on the situation. So absolute contraindication for exclusive endoscopic ear surgery, transcanal endoscopic ear surgery, probably we have to put in that way, like a very narrow stenotic ear canal where we have to do canalplasty sometimes, and also a completely contracted sclerotic dense bone mastoid. Sometimes we see only, even we don't see antrum also, sometimes completely sclerosed like situations, very rarely. And extensive cholesteatomas where there will be tip going up to the tip, and the deep cells, deep extensive pneumatized cholesteatoma with infiltrating matrix kind of the situations. We use more of microscope, and sometimes we use it. So how much time we use? Like every situation, there is a role for endoscope, probably. There is no exclusion, in my view, for endoscope. Even in contracted, we use the middle ear part, looking into the sinus tympani areas and all cholesteatoma matrix to remove. First, initially, we use the endoscope before we mess up with the dissection and bleeding starts and bone drilling starts. We use the endoscope for the middle ear first, like that. So there's no complete exclusion.
João, for you, contraindication, which kind of contraindication? Do you have some contraindication?
It's a great question, Daniele. I think it's just like the microscope. There are no such a thing as contraindications of endoscopic ear surgery. But if you talk about transcanal endoscopic ear surgery, I have to agree with Alejo that if you don't have a canal, of course, he is not going to be able to do a transcanal approach. And also Stefan wrote a very nice paper regarding the size of the canal, the contraindications regarding the tortuous canals and stuff like that. But I like to say that the indications depends on the surgeon ability to deal with the disease and to deal with the endoscope. And nowadays in 2020, I like to say that there are the controversial use of both microscope and endoscope. For instance, in cochlear implantation, sometimes you can have the use of endoscope, but this is still a little bit of controversy. As in transcanal acoustic schwannoma surgery, it's a little bit controversial. So there are no contraindications at this point for me, except if you don't have an ear canal.
Nirmal?
Yeah, thank you, Daniela. Yeah, I don't have a lot to add here. I think we try and teach our residents to have some fluidity in the surgical mind so that they understand the limits of all of the tools. So the endoscope now, 8 to 10 years on, has become such a normal part of the otologic operating room that the registrars and the residents just need to learn what their limits are with the tools. And so, as everyone in the panel has said, we'll have both tools in the operating room. And for example, if the canal is too small for the operating surgeon, they'll just use the microscope to widen the canal, then move back to the endoscope. There's no major contraindications. And often we find the residents struggling in the middle ear, as I've mentioned, with the endoscope, when they could quite easily switch back to the microscope for a few minutes, remove the blood, get a better view, and then move back to the endoscope. So we are quite fluid and dynamic in the operating room with both tools.
Thank you, Neymar. I know that Alejo, he would like to add something.
Yeah, I'm very happy that Joao put the cochlear implant on the table. I don't think that is a absolute contraindication, but quite honest, to me, it makes no sense. Doing a cochlear implant.
Alejo, this is good because you now you can affirm that the cochlear implant is a contraindication for endoscopic ear surgery. So
I think it's a relative contraindication if we're trying to move cochlear implantation in the direction that is heading. I mean, if we look at, if we're trying to do cochlear implants in a less traumatic way, and preserve hearing, it only makes sense that we follow the pathway and the direction of a cochlear duct, and the direction of the cochlear duct is perpendicular to the ear canal, so it's the opposite way. So, in the other hand, it's coplanar to the track to a mastodectomy. So it makes a lot of sense to have cochlear implants through the mastoid as opposed to the ear canal. So with that respect, I think that is a relative contraindication. Now, if you have congenital ears, you can help yourself with an endoscope in congenital ears to do a cochlear implant. And in that case, those cases, I think that would be not a completely endoscopic technique. I think that would be a combined technique, an assistive technique, both with the endoscope and the microscope, if you wanted to better recognize the anatomy of the middle ear as you're doing those implants, to better understand where to do your cochleostomy on those cases. But on a normal anatomy patient, I think that the cochlear implant is still the way to do a cochlear implant is still through the mastoid and with a microscope.
Daniel, can I say something on this?
Yeah, of course.
Yeah, Daniel, I think it's not an issue of a surgical contraindication. It's an issue that, cochlear implants are a very competitive area. Everybody is trying to up the ante, like I came up with this new stuff. And that's what happened really in our area, is that you get people who are just trying to rise and increase the size of their practice, and they're selling this endoscopic cochlear implantation, and this really they're taking down lessons that we've learned long time ago, that you should not fool around with the ear canal. Avoid the ear canal at all costs with cochlear implantation. So it's not like it's not a surgical issue. It's just the fact is that it's been used. The endoscope has been used and abused in order to promote certain surgeons' practices, and I think that's what's dangerous about it.
So it's dangerous for you. And for Mohamed, we have also Mohan. After we can ask to Mohan. Mohamed.
My contraindications will be exactly as it was mentioned by all of them. We still have cases of complicated, like complicated mastoiditis or complicated chronic suppurative otitis media. In those cases, I go directly with a microscopic surgery. Maybe sometimes, even in that situation, I may need the endoscope to get into a very narrow recess or something. So I will get the endoscope too. But to say absolute, it's this very large pathology that will need large exposure. As it was mentioned by George Wana, I will agree also with Aleo. I was going to object with Aleo, but actually he shifted again and said what I wanted to say is that endoscope and microscope in cochlear implant will sometimes be of great help. So I will agree with Aleo, it's a transmastoid in the cochlear implant, but he can in some situation use the endoscope too. So my only contraindication are those that's very, very difficult, large, extensive pathology. And of course, as it was mentioned, is the ear canal if it needs drilling or something.
So,
Daniele?
I know that one want to say something, and after Stefan go.
Yeah. As now with our experience as a group, shall we exclude using the term like a contraindication, because there is no contraindication for the tool. So there is a limitation of the tool in certain situations. That's what we discussed. In every case, we use both the tools. Sometimes some people use both. Sometimes we use exclusively one tool against the other. If we want to put as an exclusion, there is an exclusion I think we have to put for the microscope as far as the middle ear work is concerned. In my view, I think we can exclude the microscope for the middle ear, most of the middle ear work.
Okay.
We can use a completely, totally transcanal endoscopic work where there is no need to do wide axis and do more and more dissection and to limit the, kind of a dissection and all. We can exclude the microscope, and probably we, as a board, we have to contemplate on this point.
I would like to know the opinion of Stefan regarding cochlear implant and the endoscope.
Daniele.
Yeah, just before concerning the ear canal, I think that this is not really a contraindication. This is a limit, because if you have a big overhang of the external auditory canal, especially in the anterior part, of course you can decide. Can you hear me?
Yes, yes, of course.
Yeah, okay. In this case, you can decide to drill the external ear canal with an endoscopic approach, but maybe it could be easier with the microscope. But the main point, I think, is that, as Mohamed told, if you have a huge cholesteatoma with a spontaneous canal wall-down procedure, you have a big destruction of the ear canal, I'm not sure this is really useful to begin with the endoscope. I think you can begin with a microscope and use the endoscope only if you want to control, for example, the retrotympanum, the sinus tympani. But in this situation, why should we spend a lot of time with the endoscope when we can get time with the microscope? So in this situation, first the microscope.
Erosion of the posterior canal.
Sorry?
So the contraindication is the erosion of the posterior canal.
Yeah, if you have a wider erosion or total erosion, then I think you have to begin with the microscope. I think it will be easier.
And Livio?
Just a few words about narrow canal. I have experienced a lot of cases of photosclerosis, for example, revision stapler surgery, or previous surgeon for very narrow canal using a microscopic approach interrupted the procedure. So the patient, the surgeon said to the patient, it's impossible to do the operation because your canal is narrow. In these cases, with endoscope, it's possible to do the operation, to do the stapedotomy. So we can distinguish about the narrow canal or very, very narrow canal. If you have 3 millimeter, 4 millimeter ear canal, it's possible to use endoscope without problems. It's better than microscope in this case. Of course, if you have 2 millimeters ear canal, it's impossible, I think, without calibration, without open canal. But in the majority of the cases, narrow canal is a good indication, not contraindication for endoscopic ear surgery. This is my experience.
And Daniel Lee, I would like to know the opinion of Daniel regarding endoscopic approaches and cochlear implants. What do you think about?
As I just stated in the chat, there have been a few cases where if there was a challenging approach, transmastoid, transfacial recess, a small angled scope could be introduced into the middle ear through the mastoid to confirm the location of the round window. And so that's probably one opportunity to use an endoscope. And so maybe one or two cases really in my entire career where that was useful, but that's about it. I think the other indications for endoscopes in CI surgery are controversial. So
I saw that also Sadi is with us, probably, if he would like to join us in the discussion. Hi, how are you?
Dr. Hamid Sajjadi.
Yes. Good afternoon or good morning. Thank you. Yeah, I agree with everything that's been said, and thanks for asking me. For the cochlear implant, is clearly a mastoid operation, but it would be nice to eliminate the facial recess, which is currently not possible. So I use the endoscope extremely rarely in the cochlear implantation. We're helping with some of my Egyptian colleagues writing a paper on endoscopic assisted cochlear implantation for patients without the facial recess, not putting the cochlear implant through the ear canal, but through the mastoid, but then guiding it through a transcanal endoscopic approach, bringing the cochlear implant electrode through the attic, and then guiding it into the round window while looking at it endoscopically. So that's one very limited application to endoscopic assisted mastoidectomy for cochlear implantation.
Okay, thank you very much. And now I'm able to see Seiji finally with us. And so I would like to, please Seiji, thank you to join us.
Seiji, Japanese people are supposed to be on time.
Japanese time.
Not Egyptian time.
I had another meeting, emergency meeting. Sorry for this.
Also, Italian time is different. Okay, thank you very much, Seiji. Do you want to add something regarding the contraindication of endoscopic ear surgery? In your opinion, are there some contraindication, or you don't find that there are some contraindication to use the transcanal approach with the endoscope to treat the disease?
You mean cochlear implant?
Seiji? Contraindication.
Maybe cochlear implantation.
Okay, cochlear implant also for you. So at the end, I think that one of the most important problems in endoscopic ear surgery is the traditional cochlear implant. Because if you have something like anomalous round window, probably the endoscopic assisted surgery can be useful. But for a traditional, the transmastoid is perfect for the cochlear implant. And now another question is the failure or complication in endoscopic ear surgery. Did you observe in your practice some failure or complication in endoscopic ear surgery? For example, failure, we already discussed about the limits of the endoscopic ear surgery, and this is because in our practice, when we remove more and more scutum, probably we were able to observe some failure and re-retraction with the cholestoma. I don't know if this is your experience, but I would like to know from you if you are able to give me some feedback regarding the failure and complication in endoscopic ear surgery. So we can start again with our panelist. Muaz, please.
You know, I've totally missed the question because I was working on the WhatsApp trying to communicate with the panel.
May I answer that one because I have to leave? Is that okay?
Okay. So Daniela, please.
I'll jump the gun. I'm sorry I have to leave this early, but I would say a couple of times where we had to do an inside out endoscopically, and we ended up having to do more extensive mastoid work. So, and having to convert completely, just I think trying to push the boundaries, let's put it this way, of endoscopic ear surgery, and thinking again that because you feel so comfortable doing something that some of us are already becoming just more reliant on, can push us too much to that edge, and then you have to end up doing a mastectomy, a complete mastectomy. I had to do a canal wall down in a patient, for example, and then I think for me that was a failure. I mean, you're trying as much as you can to do it endoscopically and be more conservative, and at the end of the day, just thinking back, I should probably have done a canal wall down to start with.
And George, and in your opinion, do you have did you observe some failure or complication in endoscopic ear surgery?
Am I on mute?
No. We are able to hear you.
Yeah, Daniele, I'm definitely has failure, but I'm usually very, I don't combine a lot, both microscope and endoscope for many reasons, including cost and going through sterilization, drapes and all of that. So in my practice, a lot of time I choose one approach versus the other, unless really I need to look at the sinus tympani. So if I decided I don't push the limit for a canal wall up versus wall down and trying the endoscope. If I feel this is an indication for wall down, I upfront doing it wall down. So it's not like I went with the endoscope and then it come a failure and I have to take the microscope on a different time. I limited the endoscope really mainly for the strict indication of the middle ear, and anytime there is something in the mastoid, it's always microscope and it's always exclusively. I look at cost, a lot of the procedures and how much this has implication, and rarely I combine assisted unless really extensive cholesteatoma that I need to look at those. So in general, I limited one approach versus the other, and for the endoscope, at least in my hands, I limited a lot to just the middle ear part. So.
And Alejo, did you observe some failure, and which kind of failure, or some complication? For example, in the surgery of the stapes, something regarding the chorda, or if you observe something regarding in the facial nerve, because the dissipation of the heating of the endoscope, something like this?
No, I wouldn't call that necessarily a failure. I mean, have I taken the chorda on a stapes procedure? Yes, I have. Has it been intentional? No, it has not. But I think that has happened both with a microscope and with an endoscope. So I don't think that is not a tool's mistake. I think that's a surgeon's mistake when it occurs. And it happens with either way. I think that I take less chordas. I think that I can see the chorda much better where it inserts into the bone with a microscope, with an endoscope than a microscope. So I think that and we published on this, our dysgeusia results after stapes surgery are better. They're not absolute, but they're better with an endoscope than with a microscope. Now, in terms of contraindications, I echo what George said, but I think that is something that we had to learn. One of the cases that I'm presenting later on is exactly that. Is the fact that we had to learn which were the right cases to go straight into the microscope and which were the cases to go straight into the endoscope. I failed at the beginning of using the endoscope. I failed from an efficient type of view, trying to get disease that was going into the mastoid, and And I think that that wasn't efficient. I think that cost the patient. I thought that cost the system money, because cases that should have been done in 3 hours took 4, from the change from the endoscope to the microscope. And I think that could have been avoided. So if I would have chosen to do a microscopic approach to begin with. So choosing the right patient is very important ahead of time. Analyzing the scan is very important ahead of time to determine if you're going to approach this from an endoscopic or a microscopic, a fully endoscopic transcanal approach, or a microscopic or combined approach. And if you, as long as you said that from the beginning, then you're prepared for that and you don't waste time.
Danielle?
Yes.
Daniel? Yeah. Okay.
Yes.
Can I make a comment about the Stabies? I think there's a few issues with the Stabies and the endoscopic technique. The first one, yeah, I have burned one of the. I could recall like burning a Corda with the tip of the endoscope. Yeah, if you get close to it, you will be able to basically damage the Corda. The other thing that I would have to say is that when doing Stabies cases, is that sometimes if you're using a large endoscope, it's very, very hard to crowd in because you need to be close to the tissue to do your stabidotomy. So it's very hard to crowd in your drill and your with the endoscope. And the last comment that has for a while really frustrated me is that sometimes when you're using a wire piston prosthesis and you're trying to crimp the prosthesis, if the prosthesis, the wire takes out a lot of heat, there's a metal memory. So you try to crimp it and it doesn't crimp. You try to crimp it and it doesn't crimp. So that usually happens if you're like struggling a bit with the case. So that would be another issue, I would think, for the endoscope and the stapedectomy.
And Stefan, do you want to add something regarding the failure or something like, complication during surgery or after surgery?
Yeah, in fact, I think that we're all surgeons, so this is almost impossible to have no failure in our activity. I think that the main point for cholesteatoma surgery is the quality of the reconstruction of the scutum, because if the reconstruction is not good enough, we can have some recurrency, and this is a kind of failure. And this is important because the time of the reconstruction is arriving at the end of the surgical procedure, when we have spent a lot of time to remove the cholestator and so on. So we're a little bit tired, and we want to sometimes to be fast, and we have to take time for the quality of the reconstruction. The second and last point is, of course, the Stabies. I think that if we have failure, and this is the basis of my videos for the second part of the meeting, if we have failure in Stabies surgery, this can have a lot of consequences because of the inner ear and the fascial nerve. So I think that another point of failure can be concerning the ossicular chain and especially the Stabies.
Okay, and Seiji, I know that you are performing in Japan extensive scutum removal, and you are really expert to repair the scutum and performing a perfect closure at the end. I know very well you and brilliant surgeon, but did you observe a lot of failure when you are performing this, or in your opinion, now the situation is completely different and you can see something moving in a good way?
I don't want to say a lot failure, but we do a lot of scutumplasty with cartilage, and as you know, 1 year, 2 years is fine with scutumplasty, but after 3 years or 5 years, cartilage can move to to outside, outward, laterally, and there can be a retraction pocket, and that may cause recurrent cholesteatoma. So that can be failure in the long term.
Okay, so it's better to use the scutoplastic and remove just a little bit less with respect to big extensive scutum removal. And regarding Daniel Lee, did you observe the same?
I think Daniel Lee, oh, here we go.
Okay. So we can, for Mohamed. Oh, Daniel.
Yeah.
Okay, Daniel. And
Yes.
the question was regarding the failure of the scutoplastic. And did you observe any failure during your activity regarding the scutoplastic when you are removing in an extensive way the scutum, or no?
I would say yes. Early on, as I struggled to perform all of my chronic urcasis transcanal endoscopically 7 or 8 years ago, spending much more time than I needed to try to complete the operation when I could just convert it to a transmastoid approach to complete the resection. Certainly removing all that scutum and having to rebuild it was certainly much more challenging. And so, as I stated earlier, I tend to remove less scutum if I can't reach disease with a 30-degree endoscope in my hand and a curved section. I just turn the ear and complete the resection with the mastoid approach to avoid an extensive scutoplastics. I do think those can fail. They're more vulnerable to ongoing eustachian tube dysfunction and retraction. And so I think those are areas of caution to beginning endoscopic ear surgeons.
Okay. And Mohamed, where Mohamed? I would like to know him. Did you observe any complication with the facial nerve and the endoscopic approaches?
Not in my hands that endoscope was a cause or a reason for facial paralysis. That's if this is the question. So no, I did not observe that the endoscope was as a tool reason or as a complication led to a facial paralysis. I think it's on the contrary, it gives you a very good exposure on the facial nerve, and sometimes I even use it to see if there is any problems or any anatomical anomalies. It also helps me a lot to see the geniculate ganglion area and go even in the anterior epitympanic area and see better. So as far as facial nerve is concerned, I see that the endoscope is not against, on the contrary, it's more preserving for the facial nerve than with the microscope. This is if we compare. Just to mention, because of the time that we are now using, the more we follow the patient, especially with the retraction cholesteatoma and retraction pocket, and the more we try to reinforce the attic or to really do our scutoplasty, I think that now I'm starting after 7, 8 years, 10 years of following up my patients. Those patients with time start to retract again, despite that of reinforcing with cartilage. So I am in a state now, or in a phase, reconsidering a little bit the endoscope and the very limited approach. Maybe I am considering the advice of Stefano Ayash about really doing extensive obliteration, that is obliterating up to the scutum and the antrum. But this is a phase that I think I have here a small point of I will consider like failure in some of the cases of the retraction and the scutum and the removal and the reconstruction of the scutum. So it's a point of to be discussed.
Joao, did you observe any complication in your activity and regarding endoscopic ear surgery, for example, regarding facial nerve, regarding vertigo of the patients?
Failures, we all have as surgeons using microscope or using endoscope. But I'd like to say that complications related to endoscope, yes, I have a few, especially related to heat, because in the past we didn't care about the light source and the intensity of the light. Also some vertigo in some patients. But I like to say that at the beginning, we all tried to push the envelope, tried to expand the limit. So it's not a failure, but I had done some transcanal cochlear implantations, which I don't recommend nowadays, but just to try to see. And of course, the patients are well, but you can see the electrode when you do an endoscopy because it's right under the skin. So I don't consider this to be a failure, but I do not recommend this. But I had some complications with burning the chorda, burning the tympanic membrane. But also we have failures because we completely do not understand yet, even with the good microscopes or the good endoscopes, the physiology of the disease. One of the main compounds, in my opinion, about the mastoid disease or middle ear disease is the eustachian tube. And honestly, we know it, the eustachian tube anatomy, we know more or less its physiology, but we have some treatments that are not 100%, I would say, like this at this point. So my failures, I think, when we have re-retractions, or most of them, I think, are related to the eustachian tube, or even the size or the shape or the things that we deal with the eustachian tube.
Okay, and Nirmal, and in your opinion, for example, like I know the opinion of Daniel Lee, but what do you think about the stapes surgery? Probably is the last step of the technique, because you can have some complication at the beginning. What is your opinion? Nirmal? Okay.
Thank you. Yes, no, I agree. It's because the technique can be done transcanal with the microscope or the endoscope. I think it's definitely one of the operations that beginners should leave until they have some significant proficiency with other middle ear work, tympanoplasty, cholesteatoma. So I completely agree that with Daniel that it should be something that we should really have our trainees doing later on in their training.
Daniel, do you want to add something, Daniel? Daniel?
He is on mute, Daniele.
Oh, yes, now.
Sorry, I have no control over the unmute there. So, but I recall a case with a trainee where, you know, the phenomenon of sword fighting can easily occur, where the endoscope bumped the stapes, subluxing the stapes, and so you can imagine in transcanal case, for example, in a right ear, an attempted stapedectomy with the endoscope, how things could happen very quickly, and then it's too late. And so I think it's important that all of us achieve a high degree of proficiency with the chronic ear case, transcanal, manipulating disease around the stapes superstructure before one attempts a first stapes with the endoscope. The endoscope is great for elevating your flap and surveying the ear, completing the tympanotomy, and then you can go to the microscope to complete your operation. And I think to a number of very important comments by Dr. Ayash and Dr. Wana that you know, it's not a case to be taken lightly. So it requires some skill and experience. I didn't do my first stapedectomy until I did about 200 or 250 chronic ear cases endoscopically. I just didn't think it was worth the risk to my patient, and so I did all those microscopically until then.
Mohan, do you use the endoscope also when you have infiltration of the matrix in the footplanes and the stapes, or in your opinion is quite dangerous using one hand?
The question is when the matrix is in the all window scutum, means
no, not in the stapes.
Stapedectomy?
No. When the
cholesteatoma matrix, yes. I think in my experience, I feel the cholesteatoma matrix we can do better with the endoscope than with the microscope. And especially if we put a little water and under hydrodissection, the matrix will float, and you can make out very clearly, very closely you can observe, and the removal of the matrix, a thick, very thin matrix over the whole window, I feel it is more safer with the endoscope. Only thing is you have to be very, very meticulous and you have to be careful. And regarding the complications with the stay-piece endoscope, subluxation of the incus is a possible when we, because especially when we try to do it with a less and less removal of the canal bone, and we want to compromise removing the bone, more bone, and so we want to try to manipulate with the instruments. So there is a danger that way. And other thing is a burning. I have come across with the cases where the atomastoid cavities very nicely epithelialized a thin membrane in the mastoid cavity was sealed by a thin membrane. I just was examining the ear with the endoscope, and with the heat it has burned away, and the patient landed up with a cavity, big cavity problem later. Earlier, the patient was very, very happy with the cavity lined very nicely, and by sealed off, cavity was sealed off by a very thin membrane. And then onwards, the patient had a problem. And very contracted and sclerosed and scarified middle ear and retractions, where the eustachian tube probably, that's where we come across with the recurrence, failures.
Yeah, there are some questions from the audience, and somebody asked the risk of facial palsy due to the thermal injury. Did you observe?
No.
Nobody?
No.
Okay, okay, and so nobody of you observed a problem with the facial nerve with the endoscope. This is the question now. Stefan?
Yeah, I think that I had one case using, but I'm going to show you the video. One case when using fiber laser. There was no problem with the facial nerve during the surgery, but a few days ago, there was a facial palsy during 15 days. And I think this was probably because of the heat of the fiber laser. This is the only complication I had on the facial nerve with a otosclerosis surgery. And this was using a fiber laser, only one case. But the patient recovered everything in 15 days until steroid treatment.
Okay, okay, and I think that we can do the last question for everybody, and after we can see some clinical cases from you. And the question is regarding the instrumentation, because also when you are performing the section of the matrix of the cholesteatoma on the stapes, sometimes you need some instruments, and it's really difficult to perform this surgery without some curve instruments or dedicated instruments. So the question is, nowadays in 2020, we are satisfied about the instrumentation or a dedicated instrumentation, just to understand your opinion in a really fast way. If Watts, please, do you have some comment about this?
I really, and I'm using the Panetti instrument set more and more, and I really cannot, like, I don't understand how I was able to do everything without it. So I'm really, I think suction instruments, if you're serious about endoscopic e-surgery, suction instruments and angled scopes are a very, very important part of the practice of endoscopic e-surgery. So I think, yes, you need to have a more specialized equipment. But I think we have everything that so far that I feel we need.
Seiji? Seiji? Hi, Seiji.
Hello. Hi. Hi.
Instruments. Instruments.
Instrument. So
what time
we
is
need,
it now in Japan? What time is it now?
11:30 p.m.
Okay. Early.
Sleeping.
very early in the night at night. Yes, I need a angled instrument, definitely, but I don't use suction instrument not so often. So anyway, I need another instrument, and also a powered instrument is very useful when you doing scutoplasty and antrotomy and archotomy. It's very useful. Powered instrument is very useful.
And João?
Yes, I would like to have a curved shaver, as we have the shaver blades for the nose. I would like to have a shaver for the middle ear and the mastoid, especially in transcanal way, in order to remove sometimes those granulation tissues, and not cholesteatoma, that sometimes stay inside the mastoid. So I would like to have this. But I agree with Dr. Tarabishi that we have good instruments at this point, good angle endoscopes, but I would like to have a shaver.
You can do, why not? The new prototype. And
Yes,
Aleio.
right.
Aleio.
I still want to have a drill that suctions and irrigates and drills at the same time. I think that is it's doable. I think that there's other type of power instrumentations, but it becomes cost limiting to have one thing for endoscopic ear surgery, one thing for mastectomy, one thing for, if we have an attachment within the current drills that we have available, to attach it to directly to the ear that suctions, irrigates, and drills at the same time. I think that would in the long run be cost effective, and so I would like to see that. I still want to see that. I don't think that we have gotten there yet.
Mohamed, are you satisfied about the instrumentation?
Well, let's focus on the fine micro instruments, and I think that in the last 7-8 years, when we started, we were really the IWGs really were the first to start making these new instruments based on Thomasin set, because Thomasin set was originally the best, and we are still using the Thomasin dissectors, and I cannot imagine working without having these two Thomasin respiratories, the dissectors, the Thomasin dissectors, and the curved suction. And honestly, he did that in the beginning of 90s, and I think they were so important. We always say that any otologic instruments is okay with endoscopic, but the fine indications, when we're talking about extending our indications, when you see a very deep pathology and you cannot get it with a specialized instruments, curved instruments long enough, you will need to have these instruments. So far, many companies has developed lots of instruments, and I think we are now reasonably satisfied having a very reasonable instruments by many companies that are specially dedicated for endoscopic ear surgery. I will accept that. Yes, definitely we will need, maybe with time will come 1 or 2 more or 3, but basically we have a very good now armamentarium of fine instruments available for endoscopic ear surgery. But I will just give one advice: don't go and buy the whole set. Okay, try to get few of these, and maybe in another company another one or such and so, because that will make you get the best out of many instruments, because they are still expensive, and cost effectiveness is important too.
Stefan, for example, I'm using more and more piezo surgery during transcanal approach because, in my opinion, it's a perfect tool to remove the bone and perform transcanal approach. And but in your opinion, are you using a traditional set, otological set, or actually, can you suggest some instrumentation to perform endoscopic ear surgery? Are you satisfied?
Yeah, Daniel, I think that today we can do surgery, endoscopic ear surgery, most of the time with the traditional instrumentation. So I think this is important to say that if people want to begin endoscopic ear surgery, they can begin with their own traditional otology set. But there are 2 points. The first point is that we have sometimes the bleeding and we have a lot of different anatomical areas. And I must say that I'm working since more than 1 year with new instruments that we have performed, and I hope that we will be able to produce them. And I will give you all the information about that. But these instruments are really, really useful. And I'm working already with that. But I'm not able to show them because this is forbidden for me today. The second point about the piezo surgery, I used to that a lot, but now I must say that I came back slowly to the traditional drill because with the piezo, this is a little bit long. And most of the time I prefer to use the traditional drilling to remove the bone, for example, from the scutum. So I have the piezo, but honestly, I'm not using it anymore.
And one?
Yep. I think we need a few instrumentation. I think definitely we are inadequate with the instruments because we can see that with the angle scope, a lot of hidden areas, but reaching them. So we need a multiple function instruments like a suction, irrigation, and drill combined, 3 options, because we have to work with the one hand. So the powered instruments, piezo is good, but it doesn't have the irrigation and the suction combined to that. So we need to have a kind of a thing like that. And then insulated instruments to stop the bleeding along with the cutting. And the angle suction, Panetti instruments are good, but we need to have, I think Panetti should improve on the size of the suction dissectors, the thinner sizes we need with insulation and all.
Livio?
I usually use traditional instruments for middle ear, but I really need additional instruments in a particular case. I mean, if you have a very bended external auditory canal, sometimes it's difficult to get the anterior annulus, or if you're trying more and more to work in anterior angle, you have a lesion of anterior skin of the external auditory canal, you have a bleeding, you have some problems. So in these cases, I think new instruments with double banded shape can be very useful. And I try to convince the company to produce some additional instruments. Another important point, in my opinion, is instruments for skull base. Probably we have to make new instruments like Panetti instruments, but just for internal auditory canal, for acoustic neuroma, or for glomus tumor. Because the current instrument, suction and dissector instrument, Panetti or other companies, because you know we have other companies producing suction and dissector instruments. Probably these kind of instruments are very small, too small for skull base, for glomus tumor. And of course, I usually use homemade instruments. I still use homemade instruments for endoscopy of internal auditory canal during a retrosigmoid approach. So I think we need some few additional instruments. This is my opinion.
George?
Another important point, sorry. Probably the future will be a kind of combination between the microscope and endoscope. I mean, when the company will made like a robotic system for holding the endoscope, and we can move the endoscope with the finger or with feet, I don't know, and we can use both hands with endoscope. Probably this will be the final solution, the final destination of our surgery. But now it's too early. I tried 2 or 3 devices, systems of robotic to have for handle endoscope, but I'm not really satisfied. But I think in the future will be a very important advancement for our surgery.
George, do you want to add something?
No, I think, can you hear me?
Yes.
Yeah, I think that there's plenty of instrument now, and you just can use different instruments from different sets, and you can get what you want. You don't need to buy a lot. I think extra instrument is for people who are pushed the envelope, and you need, yeah, it's great to have them, but we are doing a lot of everything now without them. It would be better to have them. Personally, I agree with Livio, since I do a lot of, relatively speaking, a lot of glomus tumor. You're just gonna need a better instrument for the glomus tumors, just you can be dissecting and suctioning at the same time. That's the limitation for, at least in my hand. But overall today, yeah, I mean, I think we are way better than 10 years ago with the instruments. We used to curve the autologic sets and use that. Now there is so many different shapes, and if you pick what works in your hand, you can find anything you want in the multiple sets they are out there.
Daniel? Daniel, do you have something to add?
Nothing more to add. Excellent comments from the prior panelists. I think our instrument selection is actually quite good these days. There's a need of refinement for specific indications, as already discussed. You know, in talking about, and we haven't talked much about the camera side or the endoscope side, I would like to see less bulky, lighter weight, easier to manipulate systems. When I watch my trainees begin endoscopic ear surgery, they oftentimes struggle as far as where to place their hands and how they hold the camera and the endoscope, and it can be a bulky setup, especially if you have a patient with a small neck, no neck, big shoulder, and you're struggling with your non-dominant hand to find a place to stabilize your camera. And so I think, and also as I've seen the new 3D camera systems, which are really fantastic with beautiful image quality, they're also quite heavy and quite unwieldy for long dissection cases when you're not using an endoscopic holder. So I think refinements and improving the ergonomics of the camera system, I look forward to seeing those advancements in the next years.
Okay, and Nirmal and Seiji, if you want to add something, do you use a traditional set, or do you want to add some comment regarding the using of special instrumentation?
Daniela, I think I just echo Alejo's comments. I think the one slight deficit for me would be, it would be lovely to have a drill with suction and irrigation that we can use endoscopically, even though we do have curved protected tip drills that we can use. That would, for me, would be quite useful, but nothing much else to add.
I know that Seiji is using more and more power instruments, so if he can add something.
Yes. Recently, as you may know, Medtronic launched new curved burr, which has irrigation system. So it's a kind little bit improvement. And I'd like to say about forceps and the importance of forceps in endoscopic surgery. In endoscopic surgery, we use more and more use forceps compared to when you use microscope. So because endoscope, TES is a one-handed surgery, so you need forceps, more precise, nice, fine forceps.
Okay. And Now, I think that if somebody wants to add something, also Dr. Sadi, for example, or somebody in the audience before to start the second part. So I think that it's time to start the second part regarding the clinical presentation. And the idea is to present just 2 cases. One case regarding the endoscopic ear surgery when we wins. And a second case when the endoscopic ear surgery was not so useful and there was a regret. So we can start with the first presentation with Daniel Lee. If you are able to share your monitor, I can stop to share mine. Okay. Please, Daniel. We have to unmute Daniel. Okay, okay, here we are.
Great. Well, thank you, Danielle, again, and good morning from the beaches of Cape Cod, Massachusetts. I'm on vacation right now with my family, and we're living in a small caravan on a campsite. So if the web connection is poor, I have to blame the campsite for that. So wins and regrets in my practice. These are my financial disclosures, of which one company, 3T Medical, does produce a technology that's used in endoscopic ear surgery, but will not be the discussion topic today. So wins, and just briefly summarize, in my practice, for me, virtually all my middle ear cases can be done transcanal with the endoscope, and that's been an important addition to my practice. Ergonomically, superior heads-up procedures, whether it's endoscopic or exoscopic assisted, really provide superior ergonomics, which helps to improve the comfort and health of the actual operator, of the surgeon. Teaching opportunities, fantastic. We all know about this, and documentation. To be able to produce images for the family, for the referring physicians, really are unparalleled compared to microscopic acquired images. What about the pluses of endoscopes during the pandemic? And we published a position paper that's now in press that provides some suggestions about how to mitigate risk during this very complicated time. And so wearing a full PAPR hood, a powered air purifying respirator hood during the pandemic is very difficult when using a microscope to be able to nuzzle up to the oculars and perform a microscopic dissection over a long period of time. And for those of you who had to take care of sudden hearing loss patients in your offices during the surge, for me, wearing a full face shield and doing an injection, even though that was a brief procedure, was not very easy to do. And the shield steams up, and I'm trying to find my 3D vision through the oculars with a big face shield. Not a very ergonomically positive setup. And so these were images taken from the ORs at UC Davis by my colleagues there to show that you can do microscopic cases with a full PAPR hood, but it's not easy to complete. And so risk mitigation, I think, is another big win for endoscopes in this particular era of the pandemic. I believe that heads-up surgical approaches, whether with the endoscope or exoscope, really provide a safe view of the field when using full personal protective equipment. And these are images that Professor Marchioni generously sent to us. Again, and illustrating how you can use heads-up operational procedures with an exoscope or with an endoscope and wear a full face shield, goggles, and full PPE to mitigate risk to the surgeon, to the staff, and of course, to our patient. Thank you, Daniela, for those images for our paper. And so to introduce my case, as far as a win, is that in my practice, the endoscope really has extended my skill set to manage complex skull base pathology less invasively. And so I'd like to present a case that I performed during the pandemic, during the height of the surge in Boston. And this was a patient with left-sided oral fullness as her initial complaint when presenting to the outside otologist, with no tinnitus, no dizziness or vertigo, and no subjective hearing loss. Her COVID testing was negative. She had actually pretty good hearing overall, with a mild to moderate downsloping symmetric sensory neural hearing loss and no evidence of retrocochlear findings. These are her images. This is a T1 pre-contrast. And this is a T1 post-contrast sequence showing a enhancing a lesion with a cystic component in the region of the temporal bone, just posterior medial to the bony labyrinth. Her temporal bone CT scan findings are shown here. And the concern that prompted us to consider surgery during the pandemic was that although she had pretty good hearing and vestibular function, the lesion appears to be eroding the posterior canal, and we were very concerned about impending sensorineural hearing loss in this individual. And so for this reason and for the concern about a possible neoplastic process in the temporal bone, we elected to proceed with surgery. So differential diagnosis to the group. I think it's probably pretty clear to most of you that this is likely an endolymphatic sac tumor until proven otherwise. And so additionally, in order to understand and interrogate the vestibular residual function in this patient, we did perform CVEM testing. The full vestibular lab was closed because of the pandemic, but we could pull off a series of CVEM testing threshold measurements in order to understand her vestibular function in the ear to be operated on. And so as you can see, she has excellent responses to 3-frequency CVEM responses in both the left and the right ears. And so at least we know that she had good vestibular preservation at the time of surgery in the ear to be operated on, as well as good function on the contralateral side, at least in regards to the inferior vestibular nerve functions. So we knew that she had some ability to adapt centrally should we end up performing a partial labyrinthectomy to complete exposure and remove tumor. So our surgical approach in the end was a transmastoid retrolabyrinthine craniotomy with ABR monitoring. And we wanted to preserve the posterior canal. She had excellent vestibular function pre-op. She had excellent hearing. We didn't want to sacrifice the posterior canal for the sake of a complete gross total tumor resection. And so we used with a tent to drape over the surgical field, a 2D exoscope with a holder that was used for a two-handed mastodectomy and craniotomy, and then a 2D endoscopic approach for one-handed intracranial dissection to be able to complete section of tumor around the bony labyrinth and avoid having to drill and get better exposure by sacrificing the remaining posterior semicircular canal. Just as a brief overview showing our setup, and we can see that we have the exoscope ready to go. This is a 10-year-old, very basic 2D exoscope that we use with a drape to be able to reduce the dispersion of aerosols from the drilling. And here's one of my residents, Vivek Kanamori, who's performing the mastodectomy approach to start a craniotomy in this ear with a risk mitigation Odo tent, again, to reduce aerosols being spewed forth into the air. And so the initial approach here, this is an exoscopic view showing our mastodectomy. And exposure of a portion of the tumor, which has a cystic component. So here's the pulsations of the posterior fossodural region. And then we can use the endoscope to go past the posterior canal, which is partially eroded, and complete a gross total resection of disease, medial and posterior to the bony labyrinth. So this was obviously an approach that I would have never even thought of doing 5 or 6 years ago when I was just beginning to refine my own skill set with endoscopic techniques for chronic ear disease. And so after completing tumor resection, we did some basic dissection to understand the limits of approach to the lateral recess. And so this is the cerebellum that's pulsating. These are the lower cranial nerves, and we're approaching the lateral recess of the fourth ventricle here at the base of the 9th cranial nerve. And you can see choroid plexus as shown here. And so an endoscopic assisted retrolateral approach is feasible and can be done to spare the labyrinth and get a really beautiful view of the posterior fossa as well as the lower cranial nerves. And so a snapshot from the surgery again shows in the left ear, 9th, 10th, and 11th cranial nerves, and their cranial nerve rootlets at the brainstem, the choroid plexus, the loop of the pica, and dissection instruments. And so this demonstrates the opportunity in the future to consider doing a retrolabyrinthine approach for ABI placement without having to sacrifice the posterior canal, which is the approach that people have had to use in the past when exploring this approach for ABI surgery. And so for me, the huge win was just the opportunity to use my skill set and to extend the indications for endoscopic techniques to more complex skull-based cases, and also in this case, to be able to save the labyrinth and hopefully preserve function. And again, the lateral recess of the fourth ventricle is the target of the auditory brainstem implant array. And so the outcome for this particular patient, we achieved a gross total resection, frozen and permanent sections confirmed endolymphatic sac tumor pathology. She had preservation of her ABR responses with no CSF leak, and thankfully with hearing preservation following surgery. And so it's letting me know this is a rare tumor. It's felt to be a low-grade adenocarcinoma and oftentimes associated with von Hippel-Lindau disease. And 10% of DHL patients have evidence of an endolymphatic sac tumor. And so I don't really have a long case to present in terms of regrets, except to say that, to summarize, I believe that current endoscopic cameras are fantastic and great quality, and it survived multiple processing attempts with our OR staff after each and every one of our procedures, but they are pretty bulky and pretty heavy. And so I'd like to see refinements in creating a lighter weight, more ergonomically designed imaging camera system. 2D 4K video cameras still provide, I believe, better resolution than 3D systems. And so I think 3D systems are pretty exciting, but I don't think they're quite there yet. I'm looking forward to 8K and 16K technologies to really improve 3D video quality. Right ear surgery is still challenging for novice right-handed surgeons. And so to Livio's fantastic points about double bended instruments, we need to find better instruments to be able to make it easier for right-handed surgeons to complete right-handed transcanal dissection without bumping the canal and causing a hematoma. And finally, a lack of suction during dissection can be frustrating. Obviously, there are many fantastic options that are available to overcome this, but I think continued improvement in this arena would be very critical towards a more widespread adoption of endoscopic techniques amongst our colleagues. So that completes my presentation. So thank you, Daniela.
Thank you very much, Daniel, for the interesting case. And now I would like to invite Muad to show his clinical cases.
I had to apologize to you, Danielle, because as you know, I've changed my place of practice, and everything was on the computer, and I really don't have any access to my computer. So
don't worry. We have a lot of panelists. No problem. Next time, Seiji, please, can you share some clinical cases with us?
Not this time. Sorry.
Okay, so Livio. I saw the screen of Livio, and please.
Okay, thank you. Can you hear me?
Yes.
Yes. So I have just a small video, fast case about revision stapes surgery. You can see my screen?
Yes.
Yes. We are speaking about 52 years old woman with 2 previous surgery of the right ear for otosclerosis with persistent conductive hearing loss and normal otoscopy. This is CT scan, not very clear. Anyway, you can see the prosthesis probably out of the oval window. And some picture intraoperative. You can see here the prosthesis not in right position, out of the hole, and not in contact with the long process of the incus. And in this case, my doubt was, yes, this is a problem about the prosthesis, but I usually check the situation of the ossicular chain, all the ossicular chain, and looking in this area, I observed an hypermotility of the incus. So there was a subluxation between head of the malleus and body of the incus. This is possible. This is very easy endoscopically, and in some cases can be very difficult microscopically. So the procedure was to restore the hole, the platinotomy with a CO2 laser, repositioning the prosthesis, but how we can solve the problem of the subluxation. You know, we have a lot of solution. One solution can be bone cement. I used bone cement, but in these cases, I decided to do another technique. I hope it's possible to show you a small video. I don't know if it's possible to run. Can you see my picture, my video?
Yes, yes.
So this is the surgery, and you can see tympanometal flap. Prosthesis is here. It's totally displaced. It's not inside. Now I'm enlarge a little bit more the athecotomy. I remove the prosthesis. But look, now it's possible to see this movement of the incus is not normal. You look. So this is a subluxation between incus and the malleus. So I enlarge more my approach, and using the CO2 laser, I remove the mucosa and the capsule of the articulation between malleus and stapes. In this moment, I decide to do arthrodesis. I learned this technique by my friends orthopedics. So using a small piece of bone between incus and malleus, after a few weeks, you have a kind of fixation between bones, and then you restore a normal movement between malleus and incus. So this is a final step, and the final result after few months. Sorry. I'm sorry. And this is the hearing test after, I think, 2 months. So this is my experience. I quite new technique. I don't know if it's really new. Anyway, it works. It works. It's very simple and it's very cheap. This is our experience about revision stapes, but this is another topic. So I can stop here.
Okay. And do you have other case regarding regrets? Nobody
Yes,
wants
I have.
regrets.
Yes, I have. Now I can show now.
Yeah, of course. And after, if somebody want to do some question.
If you have a question. No question.
I don't have a question, but it's a great outcome. It's a great outcome. The results were great. I honestly did not expect it to work, but you showed it to work.
Thank you. It's worked very well, very well. It's very, very cheap, you know. So about contraindication, we spoke about this before. So a case of meningoencephalocele in the antrum cavity, it's of course not a good indication for endoscopic approach. This is a case with left hearing loss, recurrent otalgia and otorrhea, 64 years old, and this is CT scan. You can see this kind of herniation through the tegmen here, and this is MRI with the CSF leak here in the tympanic cavity. In this case, of course, the only way is to use a wide mastidectomy. My personal technique is not only my personal technique, I know also Daniele used this technique, is to find the meningoencephalocele, of course, only by microscopic approach, to reduce the brain herniation, to find very well the margin of the dura lesion, detach the dura from the bone, and then a very, very small access here, mini craniotomy, keeping this part of bone intact here. So we find the bone, the dura, sorry, here, we uncover the dura here, and then we put something, I usually use Leodura for repair this defect of the dura and bone here. So after this detachment of the dura, we put here dura mother from cadaver here, but it's possible to use cartilage or bone as you want. And then we positioning this graft between the bone and the dura. It's really important to get the medial portion of the defect, of course. In this way, you can keep a normal hearing, you can keep a normal cavity, and we solve the problem with really less invasive procedure. Because, you know, if you do a traditional middle fossa approach, we can have a risk about compression of the brain or post-op problems, etc. In this way, it's very easy, very fast, and in my opinion, it's very safe. This is a final view with bone dust and fibrin glue, and this is a procedure. So this is a typical procedure. It's not an indication for endoscopic ear surgery. It's an indication for microscopic approach. Thank you.
Okay, so these two cases, somebody has some questions, but I think that it's really clear that a meningoencephalocele and mastoid, you have to manage microscopically, and the endoscope is unuseful. And Nirmal, what about your cases?
Thank you.
Can you
Thank
share
you.
the screen?
Yes, yes. We're sharing here now. So I think everyone will agree that the probably the biggest win for endoscopic ear surgery is on this screen, and that is that there's been so many wonderful friends made all across the world over the last 10 years or so. But just to speak to my brief about wins, I think Daniela has already mentioned, but particularly in the pediatric population with my practice in this sort of scenario where we have large subtotal perforations or perforations with an anterior overhang or middle ear disease in the pediatric population, it's really the reduction in incisions in the pediatric population for me that has been the major win in endoscopic ear surgery. So this is a video on the left-hand side from 2012 with the traditional Sheehy onlay technique that I learned to manage subtotal or large perforations in the pediatric population. And you can see it's quite a destructive approach coming from post-auricular, moving the skin down medially, then removing the skin and forming a canalplasty. And now you can see in 2020, this is our registrar, our fellow doing this case with a child who has a anterior perforation, and within sort of 15 to 20 minutes we can perform a composite cartilage graft repair and get very appropriate results in a child and avoiding any incision at all post-auricularly. So for me, this is a significant win. We've seen the outcome data for this now coming through more and more, showing the efficacy and the effectiveness of tympanoplasty in children and in adults. And you can see this sort of a case with a retrotympanic cholesteatoma in a child. I would have previously performed a canalplasty, possibly posterior tympanotomy, but now we can deliberately dissect tissue off named areas out of the sinus tympani and out of the sinus subtympanicus here, areas that I could name before, but I couldn't see at all with the microscope. And we can identify cholesteatoma and dissect it in a very clean manner out of areas to reveal these regions with direct view and get quite good outcomes in children. So you can see again our data over the last 10 to 15 years is now coming out, and this is work from Livio and Daniele showing 18 to 36 month follow-up with endoscopic ear surgery showing similar residual recurrence rates. Here's work from Stephen Hoff's group in Chicago showing similar residual and recurrence rates, and of course Daniel and Michael published this work showing equivalent residual recurrence rates. But the big deal here is that the mastoidectomy rates were reduced by nearly half. And I've seen this in my own data with a significant reduction in mastoidectomies with the introduction of the endoscope. So for me, the really big win in endoscopic ear surgery is the lack of post-auricular incisions, particularly in children. And Daniela Cavello already mentioned this, but the parents absolutely love this scenario. Now, my regret involves these two people, and I think you already know who they are. But Livio and Daniela, and particularly this paper, and this really extends on their idea of the selective disventilation work that was published in 2010 from Daniela and Livio. And let me explain my regret, and that is that we now know with Attic cholesteatoma specifically, the residual disease removed endoscopically is most likely at least equivalent to the post-auricular incisions. And here's work from another board member, Adrian, that was just published this year, showing historical case control studies between 65 endoscopic ear versus 112 post-auricular, showing residual disease is at least equivocal, likely trending towards better with endoscopic. But why was I, and I think we've already touched on this, and I think there's many reasons for this, but why was I getting situations like this after 3 years of endoscopic ear surgery? Whereas now, with some of the cases I've been doing where I'm paying more attention, we have scenarios like this in 2020. And I think some of it comes back to this paper that was published by Livio in 2018 and the potential impact of endoscopic ear surgery in mucosal preservation. So this was a historical case control study, but the mean follow-up here was 5 years, so quite reasonable, showing that recurrence rates, so not residual, but recurrence rates are potentially less in endoscopic ear surgery. And the postulation was that if the case was performed endoscopically, perhaps we can preserve mucosa better, perhaps. And the other idea, I think the reasonably big breakthrough idea is that we need to recreate ventilation. I think Livio mentioned this already. And this is done by trying to reopen or recreate the primary and secondary isthmus by performing either intact chain surgery or primary OCR. And when this occurred in their cohort, they showed that there was less recurrence. So when we're talking about reducing recurrence rates, we've already touched on this, but of course nasal and eustachian tube dysfunction is important to look at, and whether the disease is sclerotic or aerated mastoid, whether we have infiltrative or easily dissectable cholesteatoma, as Joao's mentioned, and mesotympanic versus Attic cholesteatoma. But if we're looking specifically at Attic cholesteatoma and with an aerated mastoid, then now after this paper that Livio and Daniel have published, I tend to pay a lot more attention to performing primary acicular reconstruction and more attention to the actual reconstruction. So here we'll try, and I'll demonstrate this in a video in a minute. And when I'm doing disease that's involving mesotympanic as well as Attic cholesteatoma, we try to minimize the scutal removal, but we pay more attention to the reconstruction. So just to briefly run through this with a video, you can see our fellow just a few weeks ago performing removal of an Attic cholesteatoma here with the primary isthmus relatively open, but the secondary isthmus blocked in a full complete tensor fold. And you can see here he's measuring the small Attic defect here. But you can see we pay attention to doing a primary acicular reconstruction, and I now bevel the cartilage to sit into beveled Attic bone, and we try and have a significant perichondrial cuff and try and place this cartilage on top of the acicular reconstruction. So you can see here this is tragal cartilage with the thin perichondrium placed down medially, and we remove and try and create a bevel with the cartilage so that it sits appropriately. And then a primary acicular reconstruction is done if the disease is clear of the stapes. And then I fashion a cartilage cap with an 11 blade to try and create a concavity to the cartilage cap. And this way we can place the cartilage cap snugly into the scutal slot, as you can see here, and then try and pay attention to the way that we bevel our cartilage and lock it into the attic. And I think we've touched on this with our discussion earlier on today. And so you can see here, this is our fellow placing this reconstruction in and trying to place it on top and rest gently on the ossicular reconstruction. These are all sort of refinements of what Livio and Daniela have mentioned. And you can see when we have mesotympanic and retrotympanic disease, a fairly large adicotomy, so perhaps against what we've been discussing earlier in this. But you can see here we have a large tragus cartilage with the perichondrial cuff. And we take out a slot of cartilage here to allow a contiguous bit of perichondrium with 2 bits of cartilage. And you can see an example here of this sort of reconstruction from the end of last year. Again, our fellow placing this cartilage in, and you can see this independent bit of mesotympanic cartilage on the primary reconstruction, and then the attic reconstruction beveled in place here. So in summary, to try and reduce recurrence in a pneumatized mastoid, perhaps we need to look at nasal and eustachian tube dysfunction, as we've mentioned, but an important point may be that we need to recreate ventilation into the mastoid. So I'm now paying more attention to reconstructing, including a larger perichondrial flange, beveling the cartilage in the attic bone, and trying to place the attic cartilage supported onto the ossicular reconstruction so that we can achieve results a little bit like this picture on the right-hand side. So in summary, the big win is no incision in children, and the big regret was not really using the principles of functional endoscopic ear a bit earlier. So a little bit of a shout out to Livio and Daniela for publishing their work. And just for Seiji here, just to remind everyone that the Congress has been moved now to the 5th to the 8th of April 2022 in Kyoto, same venue. Thanks very much, Daniele.
Thank you very much, Nirmal. And Mohan, can you share your clinical tips? Okay. Are you able to share the screen?
Yeah, I think I'll take my help of my son. Meanwhile, you can ask somebody else.
Okay.
To do.
Okay.
Yeah,
So,
yeah.
Mohammed, please.
Okay, hi. Well, I'll share my screen. Well, Daniel, I will present a case of congenital cholesteatoma, and I consider congenital cholesteatoma endoscopic congenital cholesteatoma, exclusive endoscopic congenital cholesteatoma, as a real win for endoscopic ear surgery. And we all agree about that. It's incisionless. We can get it perfectly. And I will show you one of the case that I did actually nearly 4 years ago. And you can see now, this is a case of left congenital cholesteatoma in a 12-year-old patient. And this is a pre-operative audiogram, and he had a very large airborne gap, and it's relatively large. This is a case here. We started endoscopically, as you can see. We dissected tympanomeatal flap, and you will see this is a relatively large cholesteatoma. It's not a small pearl, and we start dissecting the tympanomeatal flap. You can see that the cholesteatoma is even going into the protympanum, a little bit in the mesotympanum, and it's so large that we started to remove the cholesteatoma. We had to go like piece by piece. This is not a cholesteatoma that you will be able to take it totally out with the sac intact. So we continue our dissection. You can see that the cholesteatoma is filling the area. This is a round window area. And here is the cholesteatoma filling the oval window area. This is a promontory. So I removed the incus, the head of the malleus, leaving the handle. This is a chorda tympani that I always try to preserve if possible. I don't rush to cut it because you can end up keeping it. Here you can see the cochleariform process with the tensor tympani tendon. And you start seeing here, this is the oval window, and you can see the matrix, how the matrix is very adherent. And this is the facial nerve. Here is the cochleariform process. You see how you can start slowly dissecting the matrix from over the foot plate of the stapes that was already eroded. Of course, this is a mobile foot plate. We were discussing during our discussion today that you can still remove slowly the matrix. You see here is your sinus tympani, and we start removing the cholesteatoma matrix that was not insinuating but over it. You see how the dissection of the matrix is coming here. This is the facial nerve. Here is your subpyramidal recess. You can see even the annulus of the foot plate of the stapes and the facial nerve. And you can see how the dissection is progressing slowly. I'm going slowly because I really want you to visualize the removal and the dissection from over the foot plate of the stapes and how we actually did the removal of the matrix that was really covering the foot plate and insinuating into the recesses of the retrotympanum medial to the facial nerve over the foot plate of the stapes. I could actually see very well here the removal. And I was, as you can see, this is the lateral canal. This is here just checking that the tensor fold is open. Here just checking that the tensor fold is open, checking everywhere, the Eustachian tube, checking the middle ear. So I could really reach a very high confidence level. You can see here perfectly. So now this is the 45-degree checking again on the, this is actually here the retrotympanum. This is the protympanum here. You see the Eustachian, the sinus tympani. You see with the 45. You see the foot plate, sinus tympani, the antrum. There is nothing getting behind here or getting. This is the antrum and the lateral canal. So I'm very well oriented. And here is the Eustachian tube and checking the Eustachian tube. So again, it was a large cholesteatoma that I could, in a very high level of confidence, reach. I could consider like a total removal. And that's for me was perfect. You can see now this is time to, I just took the last piece here, just the umbu, not to leave any epithelium. Here is the malleus, the reconstruction that I was, this is the reconstruction of the scutum. I put here the skin, the tympanomeatal flap back, and that was the tragal cartilage. Again, this is another layer of the perichondrium. And here is the cartilage. And then I put the incus that I took here. I cleaned it well, and I put it as you can see here, as a columella, and I put even the chorda tympani in place and return everything back into place here and put the gel foam. Well, that's actually here, as you can see, 1 year post-operative CT, and you can see well the incus in place, getting over the foot plate, and here is actually 1 year post-operative. You can see how the ventilation of the mastoid was great, and this is the incus. And the post-operative, I always follow the case with MRI diffusion weighted, and as you can see here, that's 1 year post-operative, and there is no signals of any recurrence. This is a patient now, 1 year later, 13 years old, and he was perfect. And I really agree, he was perfect. And this is one of the win. But I followed this patient for every year as normal. I follow the cases. And this is after 3 years follow-up. And I did actually hear. The patient did not improve or had a problem in his hearing in the left ear. So the hearing was not good. And despite of this is actually in January 2020. So it's about 3 years post-operative. And because of the hearing in the left side and CT scan and MRI post-operative, this is the MRI 3 years post, the CT 3 years post-operative, you can see here, and even the MRI diffusion weighted came out to be negative. And you can see here, diffusion weighted, no foci of restriction, no cholesteatoma. So CT, MRI, but the hearing was not as good as you will expect for a patient who is 15 years old. So now, look here, this is, I decided to operate, to do ossiculoplasty, to reconstruct, to remove the incus and put a prosthesis. So this is the post-operative here. And look, once I dissected the tympanomeatal flap, and look here. This is the place of the oval window. This is the reconstructed incus. Look here. And see what, this is the incus that was pushed anterior. And here is this pearl. And I was very keen to show you how the dissection went and how we could actually remove every part, but see how I could actually get here a small piece. This is the sinus tympani, and here is the pearl of the residual. This is the incus that was pushed anterior. This is the foot plate of the stapes and the cholesteatoma. And here is after actually removing the residual. This is the 45 degree again. You can see the foot plate of the stapes, the incus, the antrum, the round, the lateral semicircular canal, and taking out here. This is the foot plate of the stapes, cleaning the sinus tympani. Here I used the torp, that is, it's a Sachi torp that I put into place over the foot plate. This is a small cap of tragal cartilage, and again I put back the tympanomeatal flap. This is 6 months post-operative view otoscopy, 6 months post-operative, and you can see here this is the cartilage, and here is actually this is the pre-operative audiogram, and this is the post-operative audiogram. So I will say, this is okay. I will say here,
Mohamed,
yes?
just because I received some feedback that we have a really short time now.
Yes.
We are almost at the end of the conference. And I would like to ask to the board to show, just if somebody wants to show other clinical case. I know that George, he can show some one clinical case, but I would like to ask you to present in 5 minutes the other cases, because we have just a few minutes at the end of the webinar. This is just so I observe your case was a great case. I would like to see also some regrets. This
is a regret. This is showing how nothing is absolute. And despite that it's an endoscopic, you still can get residual and can get recurrence.
Yeah, but anyway, it was perfect. Anyway, because in the second operation was great. And so the final results, I think that is perfect. So thank you very much, Mohamed. It was a great case. And there are somebody that want to show some other cases. I know,
Yes.
George, please.
Listen, Daniele, I'm sharing I need 1 minute and I need to go. Okay.
Daniele.
See my screen?
After Stefan, you can show also your case. And now, George?
Yes, can you see my screen?
Yes.
Okay, so I'm gonna skip to that.
Not the screen. Not now, the screen.
Can you see it?
No.
No, okay, here, let me see. If I cannot show it, then here. What's going on here? Can you hear me at least?
Yes.
Yes, of course.
Okay. Here. I can see you, but can you share my screen, Daniele, from your end?
Yeah, you are able to share, in my opinion, the screen.
Can you see it?
Not now.
Okay, hold on 1 second. If not, I will try one more time and then I'm gonna log out and then it's fine. We can do it another time. You know, it's not the end of the world.
No, probably just to share and the screen.
Here, can you see my screen now?
Not now. I don't know why, but probably Mohamed probably is sharing also now or no. I don't know.
No, I think you should be able to.
What is the problem?
I'm saying I'm pressing on sharing and it's not sharing, so I don't know what's going on.
Nearly, may I give a suggestion?
Yes.
Yeah.
Yeah, I think we have talked more than 2 hours and a half. So I think we can show this later in another webinar. I don't know what the other board members would say. I think it was a great session, by the way.
Probably, yes. Can stop now and we can plan another session, just 1 hour for clinical cases. What do you think?
Yes, I agree. For my end, I agree. I had prepared several cases, but I think it's better to do in another time. Otherwise, people will not see.
Yeah, and I have to leave anyway. I want to say thank you for everybody, Moaz and Daniele, and it's always good to see everybody. I'm sorry, it's been 3 hours almost, and I need to get out before I get in trouble.
Me too.
Yeah, of course. Was really a pleasure to have everybody here in this webinar. And so we can plan another webinar if Moaz agree, of course, because not short, the short one, the next time, just to share clinical cases. And so thank you very much for everybody. If you want to add something, Moaz, please.
Yeah, thank you very much. Thank you all. It's a very nice session, but as Joao said, it was too long. I think we're all getting tired. When you get to be 60, my age, you don't last for 3 hours. Thank you guys, and have a nice evening. And I'll work out a detail with Danielle regarding the organization of a second session. Have a nice evening, all of you. Take care.
Thank you.
Thank you very much, everybody.
Keep safe, people. Thank you.
Keep it safe, yes.